I'm here with my good friend Christi Idavoy. She is one of our Director of Education for Polestar in the United States and also in South America. She also is a proud owner of a Polestar Studio franchise in the north area of Miami. And we've been talking a lot about this particular topic, and of course the name came from Christi. I didn't come up with the name of the Power of the Flower.
Good friend Circe.
But it is a topic that we've been researching. So Dr. Hadar Schwartz and myself and some other friends, and then our work with Pam Downey with women's health as a physical therapist, and our interest in this area. Now, I want to turn a little bit of time over to Christi to sort of define what she's seeing, what she's feeling, the passion that she has about the idea of incontinence. And that's really the topic we're discussing today, and to make it so that it's something that is discussed much more openly. I think it's something that's been a taboo to talk about. And I know even in my own family, whenever the word incontinence comes up, the physicians typically say, you know, that's just normal. Once you have children, you should expect to have it. But we're seeing this problem in other populations now too, and even in fit populations, which is what concerns me. So take a few minutes and talk a little bit about what you're seeing, and as our guest here today.
I recently became a mom, and even this idea of this being normal after having children, I don't agree with that at all. And so, recently it's been brought to my attention at the studio now that I have. I'm seeing a lot more very fit women, even instructors, yoga instructors, Pilates instructors, boot camp instructors, and they're leaking. They have leaky bladders. They haven't had children, and they have leaky bladders, and it's really all about breathing. And so what I feel very passionate about is the fact that it's taboo to talk about, as Brent mentioned. So I'd love for us to create an environment where it's a lot more acceptable to talk about, since so many women are silently suffering.
Silently leaking.
Silently leaking, as we said, the silent leakers. And also, of course, as the universe works, you start becoming aware of something, so you start seeing it everywhere. So I wrote a very short blog about this topic, and as I was writing the blog that night, a commercial came on the television for pads, and it's bladder protection pads. And then I went to the gynecologist, and I'm waiting for the doctor, and it's, do you leak when you cough, sneeze, jump, or laugh? Take this pharmaceutical drug.
The magic pill.
Yeah, so I'm like, no, just learn how to breathe, learn how to manage intra-abdominal pressure, and I think that's what we're going to talk about with
It's funny you say that. One of the funny things, when we were doing the original studies, looking at Pilates teachers, and we were looking at them, and we were taking all this data and asking them, do you suffer from incontinence? Have you had children? Have you had vaginal birth? Did you have a C-section? What do you notice on your day-to-day kind of activities? And so as we were taking this data, it was interesting to me that we didn't find a correlation necessarily with those that had children or not had children. We were even finding that some of our Pilates teachers that were in their 20s were joking about, hey, when I bounce around, I leak. And it's like, that's funny to you.
It's not funny. It's not funny.
And what are we doing? And this leads to some of the research that we've been looking at of trying to understand, what are we teaching people? Now, here we are, physical therapists, Pilates teachers, maybe yoga teachers out there listening to us. Hopefully some physicians listening to us. Maybe you can take this back to your physician and sort of challenge the idea that this is normal. You just need a pad or take a magic pill. It's going to go away. Or you do 1,000 Kegels. I mean, I even had, and it's not a problem that just affects women. It affects men as well. I have a male patient that I've shared with Pam Downey, and he had gone through a prostate surgery, prostate cancer, and the residual was significant incontinence. And the verbatim, his exercise sheet said for him to do 1,000 Kegels per day. 1,000 Kegels per day. And he was still leaking.
Wow.
I said, look, let's back up a little bit. Let's think about this. 1,000 Kegels is not going to stop your urgency or your leaking. So let's go back. And so we started working with Pam and doing some internal, external work, even changing the frame of mind, the concept of saying, like, let's let these tissues do their normal job, which is very elastic, and as you mentioned earlier, it's more spontaneous. And I think that's going to be a word you're going to hear from Polestar a lot over the next decade, is really thinking about how our movement needs to be, as Joe said, natural and spontaneous. And now we're looking at understanding from a motor control standpoint, how do we create this spontaneous organization of things like incontinence? How do we reorganize that pelvic floor after childbirth or a surgery, or just understanding that when you hold your abdominal wall all the time, you are limiting the effectiveness of your pelvic floor, and that is leading up to some of these cases where we see these young women and young men having leakage problems just because they're holding their abdominal wall so tight all the time that there's no responsiveness. So these are the things that we're looking at. You know what I want to do right now is I'm going to switch into a couple slides that talk a little bit about this and what we've been doing. And Hadar Schwartz is a good buddy of mine in the physical therapy world and the Pilates world. Many of you might even know her. And Hadar has been doing her dissertation and looking at the pelvic floor. And as we were collecting all this data together, we now have over 250 Pilates teachers that we have looked at. And our primary question was, are we able to volitionally perform a pelvic floor contraction when we think we're contracting or doing a pelvic floor contraction? And the end result after 250 people consistently across countries, different borders, different events, year to year, even with the education, is that about 45% of people, Pilates teachers, who think they're lifting their pelvic floor up are actually pushing it down. So we have a disparity, and we don't want to make this sound like this is an epidemic or a problem. It's just a statistical finding that out of 250 women, that 45% of them, so that's over 120 women, think they're lifting it up and they're actually pushing their pelvic floor down. So that was where the question started. And so Hadar and I did a pilot study where we looked at 45 persons, and we wanted to see what would happen and the difference between volitional contraction, which we already know is 45%, mechanical contraction, which is breath, which Christi alluded to, is like just learn how to breathe. Just breathe correctly. We might find that we have a lot of solution just in some simple breathing techniques. And the third one was, what does the pelvic floor do spontaneously? What should it look like? And this goes back to some great studies that have been done, particularly in the Pilates world. There was one done by Danielle Holder, and I can't remember the name of her partner who was the principal, but Trevor. And they were looking at an intravaginal device that measured intra-abdominal pressure. And they said, the literature all shows that sit to stand is one of the most standard measures for looking at intra-abdominal pressure. It also happens to be one of the places that most women, when they experience incontinence, outside of coughing or sneezing, is getting out of a chair. So they sit to stand, and they increase intra-abdominal pressure, and if they're not prepared spontaneously, they leak. And so that's what we're seeing. And so we wanted to know what happens in those three categories compared to the volitional contraction of the muscles, the spontaneous mechanical response to breathing, and then the spontaneous to a sit to stand. And so we had 45 Pilates teachers that we tested with the real-time ultrasound. And we looked at them in resting position, supine, and we used the standard, real-time ultrasound measures. However, I do think that in the future we're going to need to establish standard measures in sitting, in standing positions of actually looking at the pelvic floor when you're in a vertical orientation of gravity. I think that's another story. We'll come back with that one. Matter of fact, just to give you a heads up, I'm trying to set up a Polestar webinar with Dr. Larry Cahalan, who is a respiratory specialist in the physical therapy world and knows everything there is to know about the diaphragm and the pulmonary function, and then Pam Downey, who is a specialist in pelvic floor with women, and to come together, and we've been powwowing about this, and we want to do a webinar. So hopefully we'll have that even next month, as we're trying to do in April. So keep your eyes open and see if we can't get just some more information there. So then we did the real-time measurement of pelvic floor activity, and as we defined it, and we had 20 of the participants that thought they were lifting their pelvic floor up again, and of course they were pushing it down. So from a volitional standpoint, they used their own cueing mechanism. They used what they thought was the best mechanism, and then they told us, they lift their hand up, I'm lifting my pelvic floor now, and I'm taking the picture of the ultrasound, and you know the results of that from the study we did back in the fall. So we saw the same thing, pelvic floor dropping down when they thought the pelvic floor was lifting up. So same statistical outcome, 45%, same thing, right? Then the part two, and this was a part that was interesting to me, and this was Hadar's idea. She said, what should the pelvic floor do when the diaphragm is moving. So if the diaphragm's descending, what's the pelvic floor going to do? Theoretically.
Ascend.
Right? When it descends, pelvic floor descends. When the diaphragm relaxes, pelvic floor comes back up. And it's really what we refer to as elastic property. And so Carol Davis talks a lot about this with the fascia and the fascial system, how a lot of our function really is about elasticity, not muscle contraction. That we have a certain underlying tone in some of these muscles and it responds to the load, that intra-abdominal pressure. So out of 45 teachers that we asked to breathe naturally while we were measuring the pelvic floor with the real-time ultrasound, 41 of them, so that's getting up like 95%, 41 of the teachers had normal displacement of the pelvic floor in correlation with the dissension in the diaphragm. So that made us think that, you know, this is not necessarily a contracted pelvic floor or one that is spastic or anything like that, that it actually was responding naturally in these women with ascension and descension of the diaphragm. And then the third group that we looked at was spontaneous. We took the 45 teachers, the same ones, and we basically said, hey, stand up from the chair. Hadar had the ultrasound just over the pubic bone in a standard position, but a little bit different measure because we haven't really looked at it dynamically. And as we looked at that and standardized the measure, we found out that 39 of the 45 teachers had normal, spontaneous elevation of the pelvic floor as they were standing up. Now that to me was a big, big, big message that that led to that. And by the way, that study that I referenced was Trevor Coleman and Danielle Holder that you could look up for the intra-abdominal pressure. And what they did do, funny enough, is they compared the sit-to-stand as the gold standard to the beginning and intermediate exercises of Rella Sakowitz's book, the Pilates Mat Exercises. And they found that pretty much bar one or two exercises, there were no Pilates mat exercise that came close to the intra-abdominal pressure required for a sit-to-stand. So that was a study that really helped us understand that, look, there's a lot of things we can do in Pilates with people that already have diastasis problems, incontinence problems, pelvic floor dysfunctions, back pain. We're not going to increase the intra-abdominal pressure more than a sit-to-stand. So if somebody can do a sit-to-stand without a problem, they can participate in the majority of the mat exercises, barring ones like rollover, jackknife. The 100 came close to that, but still didn't pass sit-to-stand, which I found interesting. It had a longer period of time. So that was just a side note for you.
And just a quick question. So when they were going from sit to stand, were they exhaling, or was that irrelevant?
Didn't even ask them. We just said go from sit to stand. Right. Now, typically, people that feel weak, they're going to do a Valsalva. All right, to go up, and so you're going to see a real significant increase in that. But with these experienced movers, I think most of them just were very naturally just standing up. And I bet if we looked at it, we might ask that question. They probably were exhaling as they were standing up, because we saw the pelvic floor rise.
Exactly.
If they're holding their breath, we might see the pelvic floor descend. Yeah. So that's sort of some cool stuff. So what does this mean? And the first interpretation can be that volitional training of the pelvic floor contraction, like the Kegel, and I wanted Christi to talk to us a little bit about her impression of the Kegel in a very positive way, because I know sometimes we can talk a lot of crap about Kegels, but the idea is that, you know, the concept, as you said,
it's a good idea
gone bad. And so when they were trying to lift their pelvic floor, people trying to do Kegels, and these are experienced movement teachers trying to do Kegels, and they're doing it incorrectly. What does that say about the population that doesn't have that proprioception? What's happening when they think they're doing Kegels?
Yeah, and I mean, to bring it back to yoga, because it's, you know, Mula Bandha is something that is said, engage your Mula Bandha, as Shelley would say, in conversation and what, you know, how do we do that? And so, you know, the way I explain it in very layman's terms is that it's not like a light that you just switch on and off. You don't just squeeze and release, you know, because then you end up squeezing the global muscles that actually inhibit the spontaneous movement of these very deep stabilizing muscles like the pelvic floor. So instead, it's like thinking of it as like a dimmer of the lights, and using your breath so that you're slowly dimming it on and then you're slowly dimming it off, versus just saying, okay, now go ahead and lift it. As we see, it doesn't work that way.
And it's funny you bring that on with the dimmer switch, and it's, you know, we now know that load and alignment pretty much dictate the motor control. So without major pathology, the idea is that, for example, if we take the Pilates chair exercise, hamstring 1, right? So we're kneeling or standing in front of the chair, and we're pushing the pedal down. And it's very interesting that, and we've done this with the ultrasound, where 100% of people, if they keep their femurs vertical, right? So sometimes I got to block it with my knee, but I keep their femurs vertical, and they have to push down. Pushing down is not so hard, but as soon as they want to come back up, the first mechanism they want to do is they want to stick their butt out, right? They want to stick their butt out to be able to come up, and I don't let them. And as I'm holding the ultrasound there, as soon as they connect it and they realize I'm not going to be able to stack my spine up in that position, then they spontaneously, that you see that pelvic floor just sort of grade on. You can see the tone increasing as the pelvic floor comes up, and then all of a sudden the Mula Bandha is on.
Right, without mentioning it.
Without saying anything, I don't say anything. The Mula Bandha is on. You can see it on, and all of a sudden their spine can articulate up. And so you bring up a really good point. The Bandhas by a great guy, Simon Borg-Olivier, wrote the book Anatomy and Physiology of the Yoga Teacher of Yoga. And he defines the bandhas, because there's many bandhas, the bandhas as a co-contraction of a joint complex. And so when I think of that, it's basically spontaneously based on alignment and load. So if we have the right alignment in our activities and we choose the right load, then we should see those neuromuscular systems working spontaneously and naturally. And that's what we're trying to find. And the big question that we have, and we don't know this yet, is people with pathology. We talk about this in spine, but let's talk about pelvic floor pathology. We do not know that if we just teach good breathing and good alignment, if we would see a spontaneous return of function of the pelvic floor. And that's going to be the next level of study, that we're actually looking at groups that do suffer from pathology, like we've done with the low back pain. And low back pain, we found the same thing.
Yeah.
It was like, hey, you know what? Get good alignment and efficient movement, spontaneous organization by alignment and load and tempo. And then you see things like the multifidi and the obliques and the transverse abdominis start working spontaneously.
Exactly.
And that's what we think is going to
And
happen.
anecdotally, I mean, clients are telling me that the silent leakers, that are now talking about it, are telling me that they have improved, that they are seeing a difference doing group Pilates classes on the reformer. So nothing specific.
I was going to say, it
nothing
is a good point.
specific to them.
And Christi knows my hell-bentness on this topic, but I believe that so many of our problems in the musculoskeletal system respond to just having good overall, well-rounded Pilates classes that are focusing on mobility, fluidity, efficiency, alignment, that when the focus is on those things, these people naturally get better. Mm-hmm. Now, in the past 20 years, we've given credit to core control and pelvic floor exercises of Pilates for getting people better. And what I'm going to challenge all of you is to say, maybe it's not the attention to core control, maybe it was the attention to breath, or maybe it was the attention to spine mobility or rib mobility that actually created the change. We know people get better when they do Pilates. The question is do we scientifically know that they get better because we're doing attention to the core and the pelvic floor, or do they get better because we're paying attention to breath and overall body movement? I think that's a big question.
Yeah, and the truth is that when we pay attention to all of it, because it's all happening at once, you'll breathe well when you have good alignment, when the load is appropriate, when the timing is correct, when you're precise in your movement. It's like, I think of it as like going to the symphony and you're listening to the orchestra and you don't hear one section is not louder than the other. It's a harmony. So when we find that harmony, we wake up our intuition, and our body is wired to heal. It's wired to heal and to get better than it was after the injury.
That which we fire, we wire.
Exactly.
And what we don't fire does not get wired. So if we have bad patterns, and this is where most incontinence is tied to bad patterns related to either pathology or just poor organization, that we could see that. So that's going to be a really cool area that we look at. So basically, in conclusion, we're basically seeing that out of all of these individuals, and I mentioned earlier we're over 250 teachers now, that 45% volitionally, I think we can pretty much say, the volitional contraction of these things is probably not where we want to go.
Right, not at all.
We do want to have awareness, though, and we want to talk about it, and we want people to talk about, incontinence as openly as they would talk about, my low back hurts, or that I have, some alignment issues in my legs. And so we can take this information. And one of the things that we did is we said, look, if 95% of the people that we measured were spontaneously moving their pelvic floor correctly with breathing and with sit to stand, what is the 5%? Why aren't they? And it turned out that they were the same 5% in both groups of the breathing and the spontaneous sit to stand that did not have normal pelvic floor movement. Out of the 40 people, 45 people, they were the 5 people that didn't. So that was really interesting to me. And so we did capture 1 or 2 of them, and we went back and looked at them, and Hadar said, hey, why don't you check their diaphragm mobility, see what's going on their rib mobility. And we addressed thoracic mobility, and we addressed the diaphragm. Guess what happened to pelvic floor?
It improved.
It responded spontaneously in 5 minutes of working the diaphragm. And so that leads me to think, and again, this is not a pathological population. This is a very high-level experienced movement population. But the question that we bring up is like, maybe, just maybe, the breath work that we do in Pilates, the extension over the spine corrector, the spine articulation on the barrel, those kind of things that we incorporate might be more responsible for correcting pelvic floor incontinence problems and back problems than bringing our attention to core control and pelvic floor volitional kegels and holding. And again, I'm using my words very carefully because until we do the research, all we can do is speculate. But this is where our thoughts are going. I always like to share those because maybe some of you out there have some connections and maybe want to do some research as well. So basically, the second topic is that 95% of all teachers had normal displacement pelvic breath. And that was crucial to us to realize that breath was that important. And this also taught us the idea of elasticity, that basically is responding to the intra-abdominal pressure, maintaining the appropriate amount of pressure that we need in our intra-abdominal space to be able to move or to be able to do any of our functions. And I'm going to skip over to this idea that those 4 or 6 that did not have normal spontaneous pelvic floor activity with sit to stand or breath, that they did, that they were the ones that we were able to make a change in, 2 of them just by addressing the breathing and that. So cool area, important stuff. I'm going to back out of here now because I just want to share a little bit of that, and I want to go into some discussion and just go into some discussion with Christi now to be able to give you some ideas and some, you as teachers and therapists of really just increasing, right now, talking about increasing awareness and consciousness about the silent leaky status of a lot of our patients and our clients, and how maybe some of the language you've been using in your studio to bring a higher level of consciousness, and then all of a sudden realizing that, out of a class of 10 women, there's going to be 8 that are going like, yeah, I have that too, and I have that too, and where before, if you hadn't brought that up, it would have just saved the silent leaky thing, and they'd be wearing the pads and taking the pills and not addressing the problem.
Exactly.
So tell us a little bit about what you're doing in your studio.
Well, I mean, it's really quite simple, and I think that as Pilates instructors, we're probably, hopefully most of us are doing this, is just, things as simple as when you're teaching a dead bug or anything where you're loading the abdominal wall in supine, having people place their hands on the abdominal wall over the linea alba, so right over the split. I tell them, put your hands in line with your belly button, and as your legs are moving away from you or as you're lifting your head up, what does it feel like? What do the tissues of the abdominal wall? If you feel a little doming action going on, if you feel things expanding and bulging out into your hands, if you feel that your breath is starting to sound like this,
that's my
come back down.
That's what I do.
That's what you do, right? Come back down. Now exhale and wait for the exhale to begin, and then load your abdominal wall and notice if it changes. So do these tissues start to flatten out? So I'm just giving them a little bit of insight on, you may have not been noticing this, and if you are having this, and if you continue to load your abdominal wall, that may lead to a leaky bladder. And then right away they're like, oh, I can't do jumping jacks anymore. Oh, as soon as I mention it, then they want to talk about it. Women do want to talk about it. And I find it, even if there's men in the room, the women are like, oh yeah, and I can see the facial expression. You read the body language, and you can see when people start to identify with what you're saying, and then they start to buy in as well. And they feel like, you know what, I'm not just getting a workout here, I'm learning how to heal myself. I feel empowered when I leave this place because I understand a little bit more about what I'm doing, And whether you're doing boot camp or yoga or whatever it is that you do, not necessarily Pilates, you can do this stuff at home every day. If all you have is 3 to 5 minutes a day, you can do this at home.
Yeah.
Do a breathing exercise.
And I encourage people as well, when they're in the bathroom, even sit on the toilet, you know, to get the legs up as high as they can and just practice inhaling and feeling the descension and the ascension purely from breath.
Exactly.
At the end of Pilates class, the other thing I do is I'll have them, like the reformers, grab onto the foot bar, go into a full squat,
yes,
and just have them sort of move around and think of how can they get the elasticity and feel that sort of movement as they move the sit bone side to side, they're squatting, they're breathing, and getting that information. So let's just summarize that real quick. You know, if I understand you right, Christi, we're basically saying that by teaching them that breath changes the tone of their abdomen, it changes the tone of their pelvic floor, and just bring that little bit of consciousness without saying, oh, contract your muscles, or tighten here, or knit that together, bring the ribs, all the things that we hear on a daily basis in these Pilates classes, and really shifting our language. I think that's what we're talking about. Exactly. And of course, you know me, I love talking about language and how we can best facilitate people to move correctly by the language that we choose to use as practitioners. We put a lot of emphasis in this in Pulsar, and when you're learning to teach, you know, it's not just positive thoughts and positive language.
It's how. How do we do that? It's a great idea. Lift your pelvic floor. How? Yeah. Lengthen your spine.
And don't be afraid to tell them to do the wrong thing either, because I know sometimes, like when I like to teach bone rhythms, I say, try doing the bone rhythm the opposite way and see what happens. And they're like, I can't.
Can't move.
It's like, there you go. So it must be true.
And that heightens intuition.
Right.
And again, they walk away feeling that they understand more. Yeah. And when you heighten intuition in one sense, you heighten intuition, period.
All over.
All over.
We said, Michael Gerber said that when you heighten awareness of yourself, you heighten awareness of your impact on others. So, you know, just that little bit of awareness of their breath could actually make their home a little happier.
Exactly. Exactly.
We all need a little more happiness at home, right? I'd love to open the floor up to some questions. I'd love to hear about some of the things you're doing.
We have a question from Donna.
Donna, the question is, did you look at the difference between the function of the left and right side of the respiratory pelvic diaphragm? And Donna, that's a great question because it just came up in a presentation I was doing in Turkey last week. I was presenting this presentation, and one of the things I noticed when I was looking at the ultrasound pictures was that there were a number of them. We didn't look at the diaphragm this way, but the pelvic floor, we saw one side of the pelvic floor raised and one side descending. So there was some discrepancy. That was the first time I noticed that, and that might be something that we need to bring attention to. So I appreciate you bringing that information up. And what would be interesting, again, is the correlation is, do we see that same correlation in the diaphragm? Exactly. So when we looked at treating the diaphragm, and you can definitely have a unilateral restriction in the diaphragm and a unilateral restriction in the pelvic floor and a unilateral restriction in the abdominal wall, and so that we recognize. The question is the correlation, and that's what I want to show or investigate is, you know, if we took 100 women with pelvic floor dysfunctions, you know, preferably some that we would consider in the moderate range that represent the majority of those with incontinence and pelvic floor pain. And if we took them and we measured to the same 3 measurements that we did already, and maybe look now and add what Donna mentioned of doing a, you know, make sure we look at the unilateral, because I did pick that up and I thought, interesting that half the pelvic floor was doming, the other half was down, and everything was down relative to the previous picture, meant that they had increased intra-abdominal pressure. They had a volitional contraction of half of the pelvic floor. Might be something like a pelvic torsion, or maybe a diaphragm, one side that's not working real well, or a rib that's stuck, or there could be a lot of other things that we could look at, but it opens up a great question. Then we assign them to the 2 different groups, and so one group goes into traditional pelvic floor strengthening and core strengthening to improve their pelvic floor pathology, and the other group goes into something like just a regular respiratory breathing exercise program that we would do in Pilates, or that we might do on the OOV. We've also been having some good success with the OOV, the device from Daniel Vladeta out of Australia. Laying people on their back over the OOV and their heads down a little bit lower automatically facilitates a diaphragmatic change. And so we think that that's going to be a really cool tool for people with pelvic floor dysfunctions. And then we can compare and we can say, you know, were these people actually getting better faster because of the respiratory focus versus looking at the Mula Bandha. You know, going in and saying, let's do a Kegel.
Right.
Let's do abdominal control. And I think that we're going to see some surprising evidence coming out of that. So that's what's cool to me. Again, any other questions or comments coming, we would love to answer those and to just basically get an idea of how many of you out there are struggling and see this as being a legitimate concern or problem for the people that you serve and you work with. We do have another question from Anna. It says, thoughts, insights on hypopressive exercises. Funny you say that. We saw that at the PMA this last year. I think anybody that was there saw that demonstration and that teaching of the hypopressive. You know, I think that there's some good research coming out on it, and again, what it's messing with is the intra-abdominal pressure, and so what it's doing is creating almost like a vacuum, and that vacuum actually would elevate then the pelvic floor by creating that vacuum in the abdominal wall. My question is, as an exercise, I think it might be very valid. As far as daily life, the question is do you have retention of it? And that's the same question we're going to ask with the respiratory training. And hypopressive breathing is respiratory training, so it might be that, you know, if we can teach that exhalation and get that diaphragm to come way up and create that vacuum, does that have some kind of long-lasting effect? And did you see that at the PMA?
I've actually been exposed to that in South America. So it was pretty popular in the last few trips I took down to the southern cone of Uruguay and Argentina. And from my yoga background, I know what they were doing is they've taken a few very advanced pranayama exercises and have created an interesting curriculum around them. But again, my question would be, how functional is it? So is there an effect that correlates to sit to stand? And the other thing is, in my humble opinion background, those exercises are taught to tone the organs, and they're also to help like increase awareness, intuition, wake up the third eye, and get Kundalini energy rising from the ground up. So it's more of an energetic exercise that, will change your metabolism. I mean, I personally was very constipated when I was a young teenager and started yoga, and those pranayama exercises, the hyperpressive ones, were very helpful to change that kind of thing. But
I would imagine so, because they're moving the organs.
Exactly,
I mean,
it's moving the organs, yeah. So.
And Joseph Pilates, even if we go back to the very basic idea of the roll-up, the idea of the roll-up was to roll up the air out of the lungs and to move the organs and to get the energy moving through that.
Exactly.
Donna again had a comment and said, did you see a pattern in the asymmetry? Would love to talk to you more about this at POT in Phoenix. I will be there. Donna, we will talk, and we can take a look. I'll bring actually the slides and the different cases that I have of the clients for the subjects, and we can take a look and even do a little statistical assessment, look at the 50 slides that we see, and pick that out. That'd be great. We'd love to chat with you about that. And by the way, I will be at POT in Phoenix next week, and we have a lot of great events coming up, and we'd love to see you at any of our events. We have another question from Mara. It says, how do I deal with relax a pelvic floor that's too tight? Thank you for bringing that up, Mara, because the truth is a lot of incontinence is a hyper reflexive pelvic floor, not a hypo. So it's more those that have too much tone that leads to incontinence versus those that don't have enough. And that's going to be a great question for us to give to Pam Downey, because that's what she spends most of her time doing with incontinence, is dealing with either the hyper-reflexive or the hypo-reflexive, and being able to differentiate that with palpation skills and the treatments that she does, and we can definitely ask her that.
I was one of her subjects before I got pregnant, so I had too much tone in my pelvic floor, as most of us Pilates lovers do, and wasn't able to have a vaginal birth, and I'm sure there's a correlation there. I didn't dilate enough. And what Pam had me do, which is exactly what you do, is that very deep squat, supported. Pam would tell me to do it again, like in a door frame, where you can slide down the wall, so you're completely supported in the deepest squat that you can get into, wide feet, and just visualize your tailbone energetically moving away from your body and really just letting your tissues descend and just breathing, you know, involuntarily, observe the breath and just hanging out in that deep stretch. And
Yeah.
I wish I would have done more of that.
It's interesting you say that. You know, I've been asked to teach a lot of classes for women in their second and third trimester, especially mat classes in large groups. And, you know, most of the class that I do, I basically convert all of the supine exercises into their standing or kneeling exercise or a squatting exercise. So they can be doing, you know, the hundreds in a half squat leaning forward and doing almost like a dart position. Or we can be doing swimming with them in a hinge position. But the interesting thing is when you put them in those positions, you're actually relaxing those sit bones.
Exactly.
The sit bones are widening, and it's all preparing them for partum. And, you know, sometimes we keep thinking, oh, let's keep those muscles nice and strong.
No.
And it's like, no, that's not really what we want to do.
No.
We want to get them to relax a little bit and have that elasticity.
Exactly.
And that reminds me of our personal experience with our son's birth. And we knew Gabriel was going to be a huge baby. He was 9 pounds, 14 ounces. And if you know my wife, Lizette, she's a tiny little 105-pounder. And so we had a midwife and did alternative birthing. And the midwife spent a lot of time doing myofascial release and pelvic floor release for that birth to be natural and agile. And we really think that that was the only way that that could have possibly happened, because Gabe's head is so big, of course, as you know him. A lot of brains inside there. But the point being is that there was preparation. And, of course, physicians often aren't going to say, hey, you know, go get a midwife and do the pelvic floor releasing work. But it was internal work that made a big difference. And, you know, it's like being able to relax is how you have babies. If you're too tight, it makes it, you got to relax. And so this is an area that requires a little more education for us. And we definitely can be teaching it in our classes without even being direct about it. Just the fact that we're teaching, you know, ways to be able to think of that pelvic floor being responsive to dropping down and descending, as well as coming up, just like we talk about breath, and just give them that opportunity in every class that we teach. Fantastic. We have one more question here. Kirsten says, what can you suggest as exercise for wheelchair-bound clients on catheters? Wow, that's a great question. You know, again, what I would suggest is, depending on what level, if that is spinal cord injury or if it is a spina bifida related or muscular dystrophy, it depends on what the pathology is or what, you know, their limitations and their impairment is. But let's say that we had somebody that had a lumbar spine injury and basically was using a catheter. To me, I think, again, the biggest thing would be we know that we get the mechanical response with breath. And so I would suggest first and foremost that there would be a breathing exercise to be able to maintain the integrity of the pelvic floor that might make things like cathing and those kind of things a little bit easier for our clients. The other thing that I always emphasize is when somebody's in a wheelchair, whether they have sensation or don't have sensation, or have motor or don't have motor, is that those tissues deserve to move. So it doesn't matter if they can feel it or they can do it with motor, it's like they deserve to move. So there is lymphatic tissue, there is nervous tissue, there is myofascial tissue, the bones, the joints, the cartilage, the skin, all of these systems deserve to move. And so even if they can't volitionally do it, we're in a beautiful environment in the Pilates and gyrotonic and yoga that we can move people in ways that they could not normally move themselves independently. And I do believe that that also, by just even taking them, as we said, yeah, they can't do a standing squat, but can we get them on the trapeze table, put them into the cuffs, and pull them back into what looks like a squat? Can we put them on the reformer and load the springs up and just have them, the tissues, feel the weight and the breath of a jump board, closed chain, deep squat, bring it nice and close to them, and just let them do their breathing in that position that naturally is going to descend the pelvic floor. And I think that would also be a great study, and I was just thinking that we have access to Shake a Leg, that we could potentially do a nice little ultrasound study with people that are in pelvic floor. So thank you for bringing that up. Emily Bench, nice to hear from you. Question is, I ask my pregnant clients and men to deep squat in the shower and just pee mindfully to feel the release of the pelvic floor. Is this something you encourage? I think it's working. Everyone is given birth naturally. Again, any way that we can communicate these types of behaviors into their daily lives So that's no different than me saying at the end of class, have them squat at the end of the reformer holding onto the foot bar. If they can do it when they're going to the bathroom, squatty potties, if they can do it in the shower and just feel that relaxation, because that's what you're feeling. And you know, sometimes people try to do the exercise of let the pee begin, initiate, and then try to stop, initiate, and stop. And I mean, I think those are great activities because those are functional of people who might feel a little bit of leakage and they can actually control it and feel a little stronger. But it is anytime you can do that, Emily, that's fantastic. So even you know, they don't have to pee to have that relaxation either. So it could be just, you know, sitting in their car waiting for something, exactly. They can pull their knees up and just do a couple deep breaths into the diaphragm and feel the rib cage expand and feel the pelvic floor, and just the imagination of allowing that to happen is great. In bed, they can lay down and pull their knees up towards their chest and just really feel like they're stretching that lower floor. We have a comment from Luciana. It says, I want to share that I just started pelvic floor therapy. It's been extremely useful in learning about my own pelvic floor. The physical therapist was able to pinpoint exactly which muscles were weak and which ones were too tight. She explained that these muscle imbalances can prevent the pelvic floor from moving up and down. Once aware of my weakness, I was able to work on those specific muscles. I love this topic, and thank you so much for sharing your knowledge. Thank you, Luciana. And you bring up a couple cool things on here on the question. One that I really liked is just understanding there's disparity, and you know, this is where, you know, I defer to Pam Downey, which we'll have on the show later. So some of these questions and comments we can bring back to Pam. Today, what we really want to do is just bring the awareness to the fact that this is really a legitimate problem of leakiness for men and women, and how do we start just increasing our awareness and talking about it and gaining more knowledge and taking the information we have and applying it in our daily classes and getting our clients to do it. You know, we talk about sitting being the new smoking, and one of the things that we're up against societally is that the average person is sitting or sedentary 13 hours a day. That's not counting sleep. That's just counting before sleep. So if you sleep 6-7 hours a night, that means there's only about 2 or 3 hours that you're actually moving, and that's usually doing things like preparing dinner and laundry and you know, maybe going to the gym for an hour. But going to the gym for 1 hour is not enough to overcome 13 hours of sedentarism. Likewise, if we're dealing with incontinence, we need to have the same kind of thing. They got to pee 10 times a day. And if they are involved in activities, they got to chair 100 times a day. How do we educate them on the other 23 hours that they're not with us on that day, and the 24 hours that they're not with us on the days in between their Pilates sessions, to be more conscious and aware and to be able to relax and breathe to make that work? Emily, again, can you explain a little the relation between diastasis recti above the belly button and weak pelvic floor muscles? The diastasis recti, as you know, is when the linea alba actually splits a little bit and it tears, and it can be varying grades. One of the tests I do with the ultrasound is I look to see that when they do contract their transverse abdominis, the transverse abdominis fibers actually cross over the linea alba underneath and connect to the wall of the rectus abdominis on the other side when it's intact. So even though you might have a diastasis recti, when those muscles contract, do they approximate the line? And if they do, then I know that they can still produce intra-abdominal pressure. If I see the muscles contracting, but there's no movement here, the linea alba just bulges out, then I know that they have enough damage that that transverse abdominis and the obliques no longer have integrity to create the intra-abdominal pressure. And what we find is that when you lose the ability to maintain integrity of the abdominal wall, guess what's going to work harder? Pelvic floor. So a lot of times the pelvic floor will become hyperactive in response to a poorly organized abdominal wall. And this would be true with low back pain. It would be true with respiratory capacities. All of these things are related. Paul Hodges did a great study looking at the relation of the diaphragm, the abdominal wall, and the pelvic floor in pigs. And he would do unilateral lesions, I think, on different areas and see how it would affect the spontaneous organization of the intra-abdominal pressure. And I'll have to go back and look at that article, but I think that, you know, one of the things I remember taking away from it was just the fact of the relationship. And so there's no doubt in my mind, Emily, that if the diastasis is severe enough, it will have a reverse effect on some of the other muscles. So, for example, the low back muscles might be hyper reflexive. They might be hypertonicity. The pelvic floor might be hypertonic. It might be too much tone because they're trying to compensate for the loss of control of the anterior abdominal wall. And those are patterns we see, and we go around. We try to say, okay, what would happen if we put a nice piece of tape across the diastases and taped it nice and tight together? And then when they breathed nice and deep, would we see a relaxation of that pelvic floor that was hypertonic? How can we, test it? And those are things that we would love to hear from you and see different ideas out there that we can maybe subject to some research. Yeah. I don't know if you have any other thoughts on that idea of the diastasis rectum.
Well, I think just what's important to point out, just to help that make sense, is that all of those things work synergistically at the same time, ideally, right? So it's not, you don't isolate the transverse from the pelvic floor from the diaphragm, right? Again, it's that idea of harmony. So as you said, it's a compensation pattern, because if one part of that harmony is weak, then something else is going to have to work louder. It's going to come from somewhere else.
Yeah. We're always seeking balance, and I think again as we bring awareness, and again not thinking so much of what muscle they should be contracting.
That's what I was about to say.
I think it's a little bit more systemic than that. I think it's just about can they get the right alignment? Can they facilitate normal breath? Do they have normal movement in their hips? Do they have normal movement in their lumbar spine? Do they have any existing pathology that we need to be aware of, like the diastases, like an asymmetrical pelvic floor, spasticity, those kind of things that could be treated out? And what we've looked at so far is just looking at a normal population of women and the high percentage of them that are dealing with this leaky bladder, and how do we increase this awareness and get people to talk about it? And
something really important that we can't forget is that it's spontaneous, right? That this area functions spontaneously. So again, just to reiterate that, to say engage your transverse abdominals is not really helpful. Yeah. It doesn't work that way.
Not in the long run. And I do think that, we've gone back and forth, and of course we were the guilty ones 25 years ago talking about how important it was to
engage your transverse abdominals.
Engage these muscles. And, there's some good research out there that's showing that, for low back pain, for example, that they're in a systematic review done by a guy named Hamilton, I believe, out of England. And he was explaining that in the systematic review there was no difference in outcome of back injuries between general exercise and core control exercises. So the idea was just getting people moving was more important than having an isolated focus on a muscle group. Both of them had similar results of just moving. And I think we'll find the same thing here, is that one of the beautiful things applies is we have this well-rounded movement experience. We move into flexion, extension, side bending, rotation, combined movements. We breathe. Our legs are moving. Our arms are moving. We're connecting.
With assistance.
Right. And we have this beautiful environment that allows us to do it at the level that we can, the load that we can tolerate. And I think that's the other thing, is that we can modify. We have these great environments. And I think that general movement experiences that are efficient are much more powerful in making changes to pathology than isolated training, as a physical therapist of, let's get that TA to work on the right side, or let's get that. And it doesn't mean that we don't do that. I mean, I still use my ultrasound to go in and say, hey, look, we have one side of the pelvic floor is not contracting, one side of the abdominal wall is not contracting. And sometimes we do have to go in and do that isolated volitional contraction. But as Christi says, function is directly tied to spontaneous. And so somehow we got to transition that. The faster we can get them into spontaneous movement, the better.
And I think it also is very important to know your audience, because if your audience is that person that is sedentary for 8 to 12 hours a day, and all they do is come to a class 1 hour twice a week, it's probably not the best thing to do isolated contractions with that person.
Right.
If the person is that same sedentary person that comes to the studio 5 or 6 times a week and works with a physical therapist, and then comes and does some myofascial release, and then comes and sees a Pilates instructor, well then, yeah, that person can afford that level of detail and that sophistication. But if we're really trying to help the masses and be in line with Joe's vision of really changing the world, then we really need to think about the universal, spontaneous, least amount of effort. What is the you know, the simplest way to do this, and it's probably not that isolated contraction.
All right, we have a question from Paulina. I'm assuming this is Paulina from Polestar in Russia. Hello, Paulina. Nice to see you pop up here. I love having you on our webinars. The question is, did you mention kinesiotaping the diastasis recti? And that was what I was talking about, is doing some kinesio or even doing some mecanal taping, a little more rigid taping than the elastic taping. And basically, really, really simple. It's something that Alex Bolander had brought up. You know, you basically want to bring the tissue together and lay the tape over it and create the tension, just to substitute the idea of the diastasis. So what happens to their low back pain? Like, I'll do this with women that are, you know, 4 or 5 months postpartum that are suffering from low back pain and they have a diastasis, is I want to know, if you don't have a real-time ultrasound, you know, just tape them up and put the tape across there that acts like the glue holding the diastasis together, and then see if they feel better over a 3-day period leaving the tape on by having the ability to engage from an external connector instead of the internal connector. And in some cases where we've had women that, you know, a year, 2 years postpartum, and they've had such severe diastasis that they have no, you know, we've tested them, they've gone to the doctor, we've done the ultrasound, there's been no change. They're the ones that, with chronic low back pain, have gone in and had a repair on the diastasis, like a tummy tuck with a plastic surgeon, and have had really good results. It's one of the few surgeries that I would say, you know, if you really have a diastasis that is not connected. Now, I see a lot of diastases that can be even as much as 3 centimeters apart, and they have control and they can draw together with those muscles, and I tell them, as long as you have volitional and spontaneous control of closing that gap a little bit, that you're not a candidate for surgery. But those that have really blown that out become good candidates. And sometimes the reason why they blow it out, I think, is because they have basically contractures of their abdominal wall from holding their abdominal wall too much. And that's, you know, when you make everything about powerhouse and holding that thing, I think that you walk around all day long, it becomes short, and it doesn't have the ability to expand when you breathe or when you have a high load, like having a baby. So it can't handle those tissues, and the tissues tear. Kirsten again, how much tension on the tape? You know, that's a little bit different for everybody, and it's to a comfort level. I'm a little aggressive on it, if you ask me. I tend to, like, I make it like a little butt by pulling it together so it screams like a crack, and I tape that nice and tight. And again, if that's uncomfortable, they tell me, and then I do it less tight. If it doesn't have an effect, I might do it more tight. Because all I'm trying to do really is to evaluate, can I take off some of that pressure? Can I help restore some of that intra-abdominal pressure with it? And it's just going to be a trial test. Remember, you want to use the right kind of tape. So if you're using the kinesio tape, remember it's a stretchy tape, and it has other properties as well that you're dealing with because of the way that it's designed. It always has a little bit of a dynamic movement. If you use the mecanal tape where you put the cover roll and then the leuco tape over the top of it, that's a more rigid tape. It's not going to stretch. So if you bunch the skin too tight together, they might be walking around hunched over because the tape's too tight. So you just use your judgment based on the individual and what they feel, and I would be interested in your feedback. So if you ever do this and you've had some success or some challenges, I'd love to hear about it. I think we're about out of time. It's 11:54. I just want to remind you of a couple things coming up. One, I will be, and so will a number of other Polestar teachers, at the POT in Phoenix. We also will be at a number of POTs in different countries. Shelley will be going to the POT in Russia. I'll be in the POT in Chicago. And we know we have a number of other practitioners that tend to make their way around. We are going to have a women's health course with Pam Downey coming up in the near future, probably the next 6 to 8 months. And if you're interested in that, coming and making the trek to Miami, just let us know. Give us a call, talk to Mylyn, and she definitely can put your name down, and we'll put you down there for somebody that's interested in that course. We've also been doing something cool called the Polestar Experience. We did the first one in Nashville, and we had a really good experience at the Belmont University, and they collaborated with us with P3 Pilates. It was an amazing experience. Heather Cole was the one that sort of helped us organize it. You certainly could do the same thing in your territories if you felt there was a demand for it. But what we're trying to do is just to increase the consciousness and awareness of how important movement is to our health. And so we do a 1.5-day event that consists of a lecture for all of the people in the community. So our clients, parents, children, high schools, college, professionals that come in, and we have a 2-hour experience that includes sort of a lifestyle experience exchange. And then the next day we have a big master class that can have up to 100, 200 people. And then we have workshops that day that are looking at things that everybody could participate in, talking about sedentarism, talking about pain management, how do we take responsibility for our own health, and then we have a little reception at the end of it, and it's been really nice. We have one coming up that's scheduled on May 6th and 7th in Hadley, Massachusetts. That's going to be with one of our senior educators, Katrina Howley, and she's amazing, and she's found a location that is an indoor park. We're always looking for cool places to do this. We don't really want to do it in hotels. But if you have a cool location and you think you have a population that would be interested, we'd love to collaborate with you and bring the experience there. We'll be doing them in Los Angeles, San Francisco, Denver, Toronto. We have some that we're scheduled to do a really cool one down in Dominican Republic. So if you want to come do a little vacation getaway and do that, you could join us for one of those experiences. We'll be posting that on the website for you to see. Again, our webinars will continue on a monthly basis, so we appreciate you joining us. We also have these available for those who are not able to see it if they want to see them. We are also looking at having a very simple subscription in the future on our website, so if that's something you'd be interested in, that would have the whole index of all of the webinars, our research, and even our education platform for those of you that are already graduated to be able to have access to the edX platform. So we love your feedback. We appreciate your attention to this, and anything we can do, any topics that you're interested in, let us know. I especially want to thank Christi for taking time out of her busy day to come join us, and always appreciate sitting next to Christi. We have a special bond, and our passion is to change the world, and we want your help to do that. And this is Dr. Brent signing off. Have a great weekend.